Welcome back to the Deep Dive. If you're here, you're looking for the essential knowledge distilled from the deepest sources. Today, we are undertaking a critical deep dive into a topic that, well, it affects all of us, the pathology of neoplasia cancer. And we're examining it through the lens of its most profound, yet completely unavoidable risk factor, age.
It's the foundational determinant, really. You hear that question all the time from the public. When will there be a cure for cancer? And, that question, it reveals a fundamental misunderstanding. Our sources immediately clarify that cancer isn't one single disease.
Right. It's an incredibly diverse spectrum of disorders.
A huge spectrum. The outcome can be wildly different. I mean, you can have something like certain types of Hodgkin lymphoma, which are highly curable. And on the other end, you've got these virtually fatal, very aggressive, solid tumors like pancreatic adenocarcinoma.
So the path to controlling cancer isn't about finding one magic bullet. It's about precisely understanding the myriad causes and the pathogenesis of all these separate diseases.
That's it. That knowledge lets us target prevention, detection, and treatment in a much more effective way.
And it's important to start with some good news, right? The context here isn't all grim.
Not at all. We have to begin with the context of success. Despite the severity, the epidemiological data is clear. Cancer mortality in the U.S. has been on a downward trajectory since the late 20th century.
And that's not just luck.
No, it's a testament to applied public health knowledge. It's largely driven by two big factors. First, decreased tobacco use in society, and second, radically improved detection and treatment for the major killers lung, breast, colorectal, and prostate cancers.
Okay, let's unpack this. Our mission today is laser focused on age. We're treating it not just as, a number on a chart, but as a biological mechanism. Why is age such a foundational determinant of risk? How can the same disease, driven by the same basic genetic rules, look so completely different across a human lifespan?
The contrast is what makes this topic so compelling. It truly is. If you look at the adult patient landscape, the statistics paint an undeniable picture. The overwhelming majority of carcinomas, they happen in adults older than 55.
The numbers are pretty stark.
They are. Cancer is the leading cause of death for women in the 40 to 79 age bracket. For men, it's 60 to 79. So for the adult population, age is just the dominant context. It completely shifts the probability of a diagnosis as you cross middle age.
That steep, dramatic rise in incidence once we pass 40 and 50, that feels like a biological signature. It tells us this isn't about one single bad event, but a cumulative failure, something that needs decades to build up enough momentum to become malignant.
That's absolutely right. And to really get it, we need to move past the correlation and, dive into the specific cellular mechanics that pathology defines as driving this age-related spike in adult cancer risk.
Let's do it. Let's start with a primary engine that the source material identifies, the genetic wear and tear.
Okay, so the first and really the most compelling core concept explaining the rise in adult cancer is just the reality of time, the accumulation of somatic mutations.
Somatic mutations.
Yeah. Carcinogenesis, at its core, begins with non-lethal genetic damage. This first mutation can be from an environmental factor, it could be inherited, or it can be completely spontaneous, what we'd call bad luck in a biological sense.
I was thinking of this process as a kind of high-stakes genetic lottery where every single cell division is like buying a ticket. And you're not just buying one, you're buying millions every single day. And you need to hit a jackpot. That is, you need to get a specific sequence of these non-lethal mutations in very specific critical genes, like oncogenes or tumor suppressor genes. That's what it takes to turn a normal cell into a full-blown neoplastic one.
And the key word there is accumulation. If you're 5 or 10 years old, you've only been playing this game for a short period, your total number of tickets bought is relatively small.
But at 65?
At 65, you've experienced cell division and environmental exposure to toxins, radiation, metabolic byproducts for decades. This necessary accumulation of somatic mutations is the prime mechanism. It just accompanies the aging of cells. Repeated rounds of cell division over a lifetime are basically required for neoplastic transformation simply because proliferating cells are the most vulnerable.
And it's not just any mutation that counts, right? It has to be a critical change. I mean, in a typical carcinoma, the entire genome might be riddled with hundreds of mutations. But most of those are just noise.
Exactly. Most are passenger mutations. They don't contribute to the malignancy. They're just, like you said, genomic noise.
Yeah.
What we're really waiting for, what the cancer cell is waiting for, are the driver mutations.
And how many of those does it take?
The pathology confirms that while you might have hundreds of these passenger mutations, you typically only need about 4 to 6 specific driver mutations to fully transform a cell.
Wow, only 4 to 6.
Yeah, think about turning a normal colonic epithelial cell into an aggressive adenocarcinoma of the colon. That requires sequential hits that often involve turning on oncogenes like KRAS and turning off tumor suppressors like APC and P53. Achieving that critical mass of specific non-lethal damage just takes time. It's the slow erosion of genomic integrity over decades.
And since carcinomas, the most common type of malignant tumor in adults, arise from these constantly dividing epithelial cells. The lining of your gut, your skin, your lungs. You're constantly giving those cells new opportunities to pick up damage.
That's the link. The constant turnover of tissue and the time-dependent risk, it all fits together. Now, that covers the first mechanism, the genetic damage. But even if a cell gets a driver mutation, the body has a really robust secondary defense system. And that brings us to the second significant mechanism of age-related cancer risk.
The decline in immunity.
Yes, the secondary but still highly significant factor in older individuals is the decline in immune competence. It's a complex process we broadly call immunosenescence.
So what does that failure look like for a nascent tumor, a brand new little cancer cell?
It means the entire system for immune surveillance starts to fail. Normally, you have these specialized T lymphocytes and natural killer cells, or NK cells, constantly patrolling your body. They're detecting and destroying cells that display abnormal or new antigens, the markers of genetic damage or transformation.
And as we get older,
As we age, our T cells become exhausted. The overall pool of fresh, naive T cells shrinks, and the ability to mount a novel, robust immune response against a subtly damaged cell is compromised.
so the immune system is like a perpetual cleanup crew.
Yeah.
And in an older person, that crew is slower, maybe less attentive, and doesn't have the right tools to clear the site efficiently.
That's a perfect analogy. And the implication is crucial. The immune system's reduced ability to detect and destroy those genetically damaged cells allows tumors to evade surveillance. And we have strong pathological evidence for this. We know that people with pre-existing immunodeficiency states, especially T-cell deficits, have a dramatically increased risk for cancer.
And the source material really highlights a specific link there between immune failure and viral cancers, doesn't it?
It does. Immunodeficiency states significantly increase the risk for cancers caused by oncogenic viruses. Tumors like Kaposi sarcoma or certain lymphomas linked to the Epstein-Barr virus, EBV. This strongly suggests that a functional, robust immune system plays a huge protective role in eliminating the early stages of virus-induced transformation. And as that function wanes with age, these viral culprits gain a significant advantage in causing cancer.
That's a fascinating connection. So a general decline in immune health doesn't just make you more susceptible to, say, pneumonia.
Yeah.
It literally allows a microscopic clone of damaged cells to slip past the sentinels and establish a malignant beachhead.
Precisely. And before we move on, let's look at the full arc of this epidemiologically. There's a curious detail about the very elderly that often misleads people. The data shows an interesting countertrend, a decline in cancer deaths after age 80.
That seems completely counterintuitive. If the risk is based on accumulation and decay, shouldn't it just keep climbing indefinitely? Are the remaining 80-year-olds somehow biologically superior? Or does cell division slow down so much that the risk stabilizes?
That is the critical point to clarify. The decline is purely demographic, not biological. It's not because the remaining population is immune or their cell division has stopped being risky. It's simply because a lower number of individuals survive to reach that advanced age.
Ah, so it's a survivor bias.
It's exactly that. Cancer, along with cardiovascular disease, has already implied massive selection pressure on the population before they even get to age 80. The pool of potential victims is smaller, which leads to a statistical dip in mortality figures, even though the biological risk to any single remaining individual is still extremely high. The biological clock doesn't suddenly reverse course at 80.
That really keeps the stark chronological reality of adult cancer in perspective. Okay, so we've established that the adult picture is one of time-dependent cumulative failure, genetic hits plus immune fatigue. Now, to understand the full scope of cancer pathology, we have to rewind the clock entirely and look at when this failure happens almost immediately. Let's talk about the pediatric paradox.
This is a radical shift in pathology, and it just underscores why cancer has to be viewed as many different diseases.
The statistics are heartbreaking, but they're clear. Cancer is the second leading cause of death in U.S. children younger than 15, second only to accidents. But if we dissected, say, a typical adult lung carcinoma and put it next to a child's brain tumor, we'd find two completely different diseases with different drivers.
Exactly. And the key distinction in the etiology, the cause for pediatric cancer, relates directly back to our discussion of environmental accumulation. Childhood cancers are much less likely to stem from chronic, long-term exposure to environmental carcinogens.
Like the decades needed for asbestos-related mesothelioma or tobacco-driven lung cancer.
Right. Children simply haven't lived long enough to accumulate that level of somatic damage.
So if the environment is largely off the table, what's the primary driver of these early life malignancies?
They are far more likely to be caused by inherited mutations. These are germline mutations. They're either passed down from a parent or they happen spontaneously very early during fertilization or embryonic development. And they particularly involve mutations in critical tumor suppressor genes.
So instead of needing 55 years to acquire the required 4 or 5 driver hits, the child starts life with first 1 or 2 hits already preloaded into every single cell of their body. It's like a fast-track genetic predisposition model.
That is precisely the distinction. And this explains why you almost never see adult-type epithelial cancers in kids. Carcinomas, which rely on decades of epithelial turnover and environmental carcinogen exposure, are exceedingly rare in children.
So what takes their place? We're talking about a unique spectrum of childhood cancers.
We are. The two dominant killers in children are acute leukemia and distinctive neoplasms of the central nervous system, so brain and spinal cord tumors. Those two groups alone account for about 60% of all childhood cancer deaths.
And the sources give a very evocative collective description for the other common neoplasms of infancy and childhood, grouping them by how they look under the microscope.
Yes. Pathologists often refer to these as the small round blue cell tumors. It's a descriptive name that reflects their morphology. Dense, tightly packed cells with very large nuclei and very little cytoplasm, which gives them a blue, undifferentiated look when they're stained.
Can you detail the members of this distinctive group for us?
Certainly. This group includes some of the hallmark pediatric pathologies. You have neuroblastoma, which is a tumor of primitive nerve tissue, Wilms tumor, a cancer of the kidney, retinoblastoma, a malignant tumor of the retina, acute lymphoblastic leukemia, or ALL, and rhabdomyosarcoma, which is a soft tissue cancer that arises from skeletal muscle precursors.
What's the profound significance of that list? These are tumors of the nervous system, kidneys, primitive muscle, not the epithelial linings we talked about for adults.
Their cellular origin is the key. These tumors frequently originate from embryonal or stem cell remnants, primitive, undifferentiated cells that are highly proliferative during rapid development. This strongly aligns with a genesis rooted in inherited genetic flaws or mutations that happen during the embryonic period.
So, if the adult tumor is a maintenance error, a failure of repair over time, the pediatric tumor is more of a developmental error.
It's the difference between a house slowly decaying over 60 years versus a house being built with a structural flaw in the foundation from day one. And the genomic analysis is striking. While an adult carcinoma might have hundreds or even thousands of mutations accumulated over decades, many pediatric tumors, especially leukemias, they often present with a surprisingly simple genomic profile, sometimes just a handful of driver mutations. They don't need the time to accumulate damage because that initial inherited flaw was so catastrophic to the cell's control systems.
That really simplifies the pathology into two paradigms. The slow, complex accumulation model of the adult versus the fast-track, simple predisposition model of the child. Now, how do we connect these two vastly different presentations back to a shared molecular foundation?
The shared foundation is the definition of the disease itself. All tumors, regardless of age, are fundamentally a genetic disorder of cell growth. Whether it's acquired over decades or inherited at conception, the disease is triggered by mutations affecting a single cell and its clonal progeny.
And the result of those mutations, inherited or acquired, is always the same: altered gene function that gives the neoplastic cells a survival and growth advantage. It lets them proliferate independently of normal physiological control.
This is where we can fully integrate the concept of genomic instability, which is the central driver of cancer risk. In older adults, we see the accumulation model at work. The natural aging process, coupled with environmental exposures and chronic inflammation, actively promotes the accumulation of stochastic or random genetic damage over time, slowly reaching that necessary critical mass.
Whereas in children, it's a predisposition model. The critical starting mutations, for instance, a germline mutation in the retinoblastoma gene, the retinoblastoma, are already present at birth. That existing genetic flaw provides a head start on the path to cancer, and it effectively bypasses the long latency period needed for environmental and somatic accumulation.
Think about the Dreber gene in the eye. A child with an inherited Reber mutation already has one non-functional copy of that tumor suppressor gene in every single retinal cell. The cell only needs one more random hit to the second healthy copy of the Dreber gene, a somatic hit, to lose control completely. A normal adult starts with 2 healthy copies and needs 2 sequential random somatic hits. That makes the process much slower and way less likely in childhood. The inherited flaw reduces the time needed for transformation from decades to just months or years.
This idea of genomic instability, it isn't just relevant for clearly malignant cancers, right? It also helps pathologists categorize the risk of benign tumors. I mean, why are some benign masses considered high risk or precursor lesions, while others are basically ignored?
This distinction is critical clinically. Our source material cites the example of the colonic villus adenoma. It has a very high risk, sometimes 50% of progressing to a frank carcinoma if it's left untreated. Now contrast that with a common uterine fibroid, a leiomyoma, which carries a negligible risk of malignant transformation.
They're both benign, non-spreading masses.
Yeah.
So why the massive difference in the risk profile?
The prevailing suggestion is that the benign tumors that pose a true malignant risk, the precursor lesions, are the ones that already possess that fundamental cancer-enabling property, genomic instability. They've already acquired sufficient molecular derangement to make them inherently unstable and prone to acquiring those final devastating mutations, regardless of the patient's age.
So it's the intrinsic genetic instability that determines the risk profile, not just how it looks or how big it is.
Exactly. A benign tumor might just be a localized cell proliferation, but a precursor lesion is a genomic time bomb. It's already past the point of stable equilibrium, just waiting for one more hit to become invasive.
Okay, so let's move to the clinical application. Understanding that carcinomas present primarily in adults 55 and older. That provides a clear, rational mandate for prevention, detection, and screening.
It does. The clinical manifestations drive our public health timing. If the vast majority of lethal cancers are diseases of the middle-aged and elderly, that's where we have to focus the bulk of our resources.
And we have a fantastic real-world success story based on this understanding. The dramatic reduction in cervical cancer deaths in the U.S., which is largely attributable to the Papa Nicolau or Pap smear test.
It's a perfect example.
Now, here's a probing question based on our discussion. If age is the dominant driver of accumulation, why are we primarily screening women in their 20s, 30s, and 40s? Wouldn't the highest yield for full-blown invasive carcinoma be in women in their 60s and 70s?
That is an excellent point, and it highlights the strategic genius of the screening process. We're screening the younger, middle-aged demographic specifically to catch the precursor lesions. The Pap smear detects dysplasia and carcinoma in situ those cells that are already genetically unstable and display all the cytologic features of malignancy but haven't yet breached the basement membrane.
So we catch the genomic time bomb before it explodes.
Exactly. We mitigate the age-related risk by treating the non-invasive precursor years or even decades before it develops into the invasive age-associated carcinoma that would become clinically evident in the older population. This strategy effectively interrupts the accumulation timeline.
This focus on interception brings us to the ultimate, often fatal consequence of unchecked progression: metastasis. For adult cancers that have had decades to evolve, how does that extended timeline affect the likelihood of a cure?
Metastasis, the establishment of secondary tumors in physically discontinuous sites. That is the event that defines malignancy, and it unequivocally reduces the possibility of a cure. The tragedy is that because adult cancers develop silently over such a long period, many tumors have already disseminated microscopic seeds through lymphatic or hematogenous spread by the time they're diagnosed.
So in the elderly patient, the problem is twofold: the accumulated genetic damage driving the tumor, and the time the damage has had to evolve the necessary traits like motility and invasiveness to escape the primary site.
That's correct. Effective means to block metastasis are paramount, and this leads us to revisit the host-tumor interaction in the aging body, particularly the inflammatory microenvironment.
We briefly touched on chronic inflammation being a cancer-enabling acquired condition. Can we define exactly how that fertile soil accelerates the process in older adults?
This is a critical link between general aging and carcinogenesis. Age-related chronic conditions, things like inflammatory bowel disease, chronic gastritis, persistent reflux esophagitis, they all fuel a constant cycle of cell damage and compensatory proliferation. Any chronic irritation demands that the tissue constantly repair itself, which requires repeated rounds of cell division.
So if you have chronic reflux, your esophageal lining is constantly trying to heal itself. And that rapid, sustained cell division in the context of persistent damage creates the perfect environment for somatic mutations to accrue faster than normal.
It acts as an acceleration loop, but it's more than just proliferation. Chronic inflammation involves activated immune cells, macrophages, and neutrophils, which release unstable molecules called reactive oxygen species, or ROS. These are highly reactive molecules that contain unpaired electrons.
Which is where the direct DNA damage comes in.
Yes. ROS are essentially molecular shrapnel. They actively attack and puncture DNA strands, causing damage that accelerates the mutation accumulation process central to aging and carcinogenesis. So chronic inflammation simultaneously increases the pool of susceptible tissue stem cells and bombards them with DNA-damaging agents. The aging microenvironment is, therefore, an active accomplice to the tumor.
Okay, here's where it gets really interesting. If we recognize that aging is fundamentally about the accumulation of genetic and environmental damage, can modern medicine intervene directly in the aging process itself to reduce cancer risk? What are the future directions pointed to by current research?
Well, our pathology sources emphasize that new analytic methods and targeted therapies are completely redefining the treatment landscape, particularly for older patients. Because elderly patients have had decades of mutation accumulation, their tumors often possess complex and heterogeneous genetic profiles. A single blunt chemotherapy often fails because the tumor has multiple escape routes.
So instead of a cytotoxic, one-size-fits-all approach that harms all dividing cells, you're using the tools of genomic analysis to identify the specific unique driver mutation, say an EGFR mutation in lung cancer in that 75-year-old patient's tumor.
Precisely. We are moving toward precision medicine, treating the molecular signature, not just the tissue type. The source highlights these emerging genomic themes in cancer. For instance, sequencing the tumor reveals the specific pathways that are hyperactive, perhaps a defect in DNA repair, or an overactive growth factor receptor. Targeting that specific lesion with a monoclonal antibody or a small molecule inhibitor drastically improves specificity and reduces collateral damage, making complex treatment viable even for the older, frailer patient.
And linking back to the microenvironment, there's the highly promising research into cellular senescence.
Absolutely crucial. Senescence is a biological state where a cell stops dividing in response to damage, but it doesn't die. These zombie cells accumulate massively in aging tissues, and senescent cells actively secrete a cocktail of inflammatory mediators known as the senescence-associated secretory phenotype, or SSP.
Wait, so these cells that stop dividing, which on the surface sounds like a good thing, are actually creating the fertile inflammatory microenvironment that promotes cancer in their neighbors.
That is the paradox. They're supposed to be a protective mechanism against early malignancy, but over time, their presence fuels the very chronic inflammation that accelerates the aging process and promotes carcinogenesis. Research focusing on clearing these senescent cells, a field called senolytics, aims to disrupt this age-related inflammatory loop. By removing the source of chronic inflammation, the hope is to reduce overall cancer risk and improve overall tissue health, mitigating one of the two primary mechanisms driving adult cancer.
That is a profound integration of aging biology and cancer pathology, treating the aging host itself to prevent the disease. The host isn't passive, it's an active, permissive environment.
It highlights that the most effective future strategies will be those that address the patient's biological age and microenvironment, alongside the specific tumor genetics.
Let's bring this incredible detail back home and summarize the key takeaways on age and cancer for you, the listener.
We've established two fundamentally distinct age-based paradigms of pathology. In the adult, cancer is a time-dependent, multi-hit disorder. It's driven by the slow, decades-long accumulation of somatic genetic damage, and it's significantly accelerated by the decline of immune surveillance and the promoting environment of chronic, age-related inflammation.
And in the child, cancer is defined by the fast-track mechanism, severe, inherited, or early germline mutations, often in tumor suppressor genes that provide a catastrophic genetic predisposition. And that leads to a vastly different specific spectrum of tumors rooted in primitive embryonal cell remnants.
Ultimately, all the source material reinforces that cancer is a genetic disorder. The critical variable that dictates presentation, prognosis, and treatment is the timing and the source of those critical driver mutations. That defines the disease's path across the human lifespan.
So what does this all mean for you, the learner? Understanding this distinct molecular basis of pediatric versus adult cancers informs drastically different prevention and treatment strategies. It emphasizes that age is not just a demographic category. It is a powerful driver of pathology that dictates what kind of cancer we screen for and how precisely we must treat it using modern targeted therapies.
Which leads us to our final thought-provoking question, tying together environment, genetics, and age. We know that genetic and environmental factors interact in complex ways. For example, studies have shown an unexpected increase in breast cancer risk in women with BRCA1 and 2 mutations who were born after 1940. And this is possibly due to modern age-dependent changes in reproductive history, like later first pregnancy or decreased total breastfeeding time. Given that complex interplay, what currently subtle environmental or lifestyle shifts, perhaps relating to chronic exposure, diet, or the microbiome that are beginning today, might be dramatically influencing the rate and type of cancer affecting future generations when they reach their high-risk age bracket, say 50 years from now.
We are planting seeds of risk today that will only germinate decades down the line. It's a sobering realization that the pathology of age is constantly evolving. That's all the time we have for this deep dive. Thank you for joining us.
Thank you.